Um I thank the organizers for inviting me to this webinar. I mean, it's a pleasure to be amongst all of you. I'll be talking about differentiating glaucomatous from non-glaucomatous optic neuropathy. Um, I'm really excited whenever I see new glaucoma patient because every optic nerve is different, and so you have these challenges to diagnose glaucomatous from a non-glaucomatous optic neuropathy. So you can see that, these are pictures of normal optic disc, but they all look different. So definitely there are criteria, which would really help us in deciding, which optic disc has glaucomatous features. So the first thing I do when I see an eye is, I always dilate them, because that is the way that you get maximum information from the patient. So, and the first thing that I see when I'm examining a patient is what is the size of the optic disc, whether it's a small, medium, or large optic disc. Because all of us, we know that a small optic disc may not have, the cup can be very small and be normal, whereas a large optic disc can have a large cup and still be normal. So how do you establish the borders of optic disc? So this is the peripapillary scleral ring, which is not a part of the evaluation. So please, whenever you are seeing an optic disc, just exclude that out. And the area which is inside this margin is the actual optic disc. So how do we measure the optic disc? We measure the slit lamp reticule multiplied by the correction factor. So you make a thin beam of slit and you measure from the edges of the little ring. And because I use a 90 diopter lens, so I multiply it by 1.3. And so you can see that, that the medium optic disc has a huge variation. It can be towards a smaller size and a larger size. So for simplicity, what I do in my clinic is that, when the optic disc size is towards the small optic disc, and I write MS, so that, it just tells me that it is a medium optic disc, but towards a smaller size. And when it is towards 2, then I write M, which means that it is a optic disc. It's a medium in size, but it's towards a larger size. Because it is the size of the optic disc that is important to us. So coverage ratio is something that is universal. Everyone does it. And the maximum coverage ratio can be 1:1. What I like to do is the rim disc ratio. It is actually the rim which is important and gets affected in glaucoma. And so the mini quadrant, the maximum rim which is present is 0.5. So suppose this is the optic nerve. The coverage ratio is 1:1, but it is best to uh, uh, tell it in terms of rim disc ratio. So if I have to describe this disc, and then I can say that the rim disc ratio is 0.15:1, which is present nasally, and in the rest of the quadrants there's no rim. Suppose this patient is lost to follow and the patient comes back to us 3 or 6 months later, and we see that the rim is actually down to 0.01:1 nasally. In the clinic itself, it is easy for us to quantify as to what is the rate of progression and how fast the patient has progressed. So similarly, you can do this rim disc ratio in any quadrant, and it actually makes you look at the rim so carefully, so that if there is any change in any of the quadrant, you can note that change. Last but not least, what is most important is the retinal fiber evaluation. It is so it is this evaluation that tells you whether it separates a patient who may have glaucoma or who may not have glaucoma from the glaucoma suspects to early glaucoma. So these are seen as bright and fine striations, and they represent tissue canals in which processes of the molar cells gather the axons together into bundles of 20 microns. They are usually seen vibrantly in the supratemporal and region, which is important to us because it is the poles which gets affected in glaucoma first. It is thinner in the nasal and the temporal quadrant, like 1 axon per bundle, and that is why it is not visible to us. So whenever you see that any area of neuroretinal rim thinning, you also see the corresponding RNA defect. So in this case, because there is bipolar thinning of the neuroretinal rim, and you see that there is beautiful wedge defect that has formed, and any defect is seen as a dark area. You can also appreciate that in the red free light and in the black and white pictures. So it is in the early and the moderate glaucoma where you get a pattern to the RNFL loss, but whenever there is a diffuse loss of the neuroretinal rim, like in very advanced glaucoma, there is no pattern to it. Okay, you don't see a pattern because there's a diffuse loss of the retinal fiber layer, and you see the vessels standing out. So initially, how did I start? When I started, one tip I would like to give out is that, dilate all normal patients, at least 500 normal patients, where you get to see a good NRR and you see how the RNFL looks like. So that way, when you come across a patient where there is something on the neuroretinal rim and you are trying to appreciate the RNFL, then you can make out that the RNFL, that there is RNFL loss. So I'll be discussing a few cases with you. So this is a 42-year-old male where the pressures are 18 and 20 with open angles. And you can see that, both the optic discs are small in size. So in the right optic disc, you can see that, there is a regular margin of the cup, and the cup is around 0.3:1, which is not expected in a small disc like this. You can also see that the cup is also getting slightly deeper, which is not normal for a disc like this. You can see this by the bending of the blood vessel. But when you go and see the RNFL, you can see that the RNFL still looks intact. But if you go to the periphery and see, you can probably make out that, there's some RNFL loss that's happening in the periphery, but which has not reached to the optic disc as yet. So definitely this eye is has glaucoma suspect, is a glaucoma suspect patient. But I always thank God for the two eyes that we have, so that you have the other eye for comparison. So if you look at the left eye, you can see that the cupping is much more in this eye. The rim disc ratio is around 0.01:1 inferiorly. And when you look at the RNFL, you can see that superiorly, where the neuroretinal rim is good enough, the RNFL is also vibrant and it's full, you don't see any defect. But inferiorly, when you look for the RNFL, you see that there is a diffuse loss. So you can also see the diffuse loss here. So definitely this patient has glaucoma and needs treatment, and that the left eye is more severely affected than the right eye. So in this case, if for the right eye you're not going to start any treatment, you can keep it under observation. But this eye definitely will end up showing some defects later on in the coming time. So this is one of my favorite patients. She's a 51-year-old lady gynecologist, and she always had pressures checked multiple times in the high teens. She never went beyond 20. She had open angles, and then if you look at her disc, the disc looked pretty healthy. There's some tilt of the optic disc, but if you look at the neuroretinal rim, it looks pretty healthy, and it's a large optic disc. But when you dilate and see, you can see that there is a nice RNFL defect which is formed inferiorly, and this is very, very typical of a glaucomatous damage. So in this case, the fields were definitely, normal, and the OCT was showing some yellow changes inferiorly. But whenever you see a defect like this, at least you are confident that, this patient is definitely having early damage, and you can discuss the management protocol with the patient. Similarly, to detect an RNFL loss, you have to concentrate wherever you feel that, that my neuroretinal rim is going thin. Like in this patient, it's a large optic disc. You can see some beta changes, and the pressures were definitely a little high for this patient. And when you see the neuroretinal rim here and you see the RNFL, you can see that inferiorly it is. But superiorly, you see that the RNFL stripes minimal, and then here you can appreciate the defect. So that is how it helps us. So this is a 42-year-old male who has got some amount of cataract in both the eyes, the vision being 612 and 618. Again, if you just look at the optic disc, it's a medium optic disc, and the neuroretinal rim is fairly looking okay with a rim disc ratio 0.2:1 and a CD ratio maybe 0.7. But this kind of disc, if you do not dilate and look at for the RNFL, you may miss out the early loss. So in this patient, you can see that there's a localized RNFL defect which is formed here. And in the left eye, if you see that the damage is definitely much more. You can see that, you know, there's hardly any rim in this quadrant. In a nasally, you can see that the rim is 0.15:1, and there is a diffuse loss, RNFL loss in both superior and inferior quadrants. The patient also has some has BRVO superiorly. So maybe these are the patients where even if the pressures are 20 and the disc may look healthy, but if this RNFL has formed, then you know that early damage has started to happen and you might want to treat this patient. Similarly, this is a 40-year-old male who has a family history of glaucoma. And if you just look at the optic disc, now this optic disc, the optic discs are medium in size and they were looking healthy enough. Even the cup is not very deep. So, but if you look beyond optic disc in a dilated examination, then you can appreciate this RNFL defect which has started to form here. So obviously when you see a sign like this, do not take it lightly. On the other hand, you know, this obviously this the left eye has more cupping than the right eye. It's around 0.7:1, and there's a thinning happening which is inferiorly. And when you look for the RNFL, you see that the superiorly it is okay, but inferiorly you see a wedge defect. So similarly, it is being shown here. So this is a 45-year-old female and she was labeled as a disc suspect elsewhere, and the pressures were again 16 and 19, not much. I mean, it is mid to high teens. And when you dilate this patient, you see that the right eye has got, the RNFL is pretty okay intact. But in the left eye, if you see, you can see that there is thinning of the new retinal rim here, and corresponding to which you can see this nice defect that is formed. So I think you should direct your concentration to any area of neuroretinal thinning, and corresponding to which, if you get an RNFL defect, those are very characteristics of glaucoma. And you can exactly say that, you know, I'm having more damage in this area. And also by just looking at this optic disc, you should be able to predict what kind of visual fields I'm going to get. Like in this patient, because of this notch that is forming here, you'll be definitely expecting a superior arcuate scotoma or an incomplete arcuate scotoma. Whereas superiorly, you can see that RNFL is still okay. So, you know, you may not get anything in the inferior visual field. So like this, so superiorly, so in the left eye, you are getting an arcuate scotoma, but inferiorly, the disc definitely looks that, you know, that the margin are getting more distinct, but still because of the intact RNFL, you also don't get any field changes. So you should be able to predict, you know, the kind of visual field and OCD that you're going to get by looking at the optic disc. And it should not be reversed that, you know, in the disc you're not getting any findings, but the field is showing something, so this patient must be having glaucoma. It's not like that. It should always be a clinical examination of the optic disc where you are definitely getting a thinning with the corresponding RNFL defect, and then you are predicting the field. It is difficult in myopic eyes where the disc is tilted, torted. But in this case, if you see this patient, because of the optic disc tilt, one edge of the side to which the optic disc tilt happens, there the stellar ring is thin. On the other hand, the other side is lifted up. So here the stellar ring is actually thicker than usual. So that is how you define tilt. So here you can see that if you minus the stellar ring, that the neuroretinal rim is definitely getting thinner here. And in myopes, you usually do not get a deep cup, maybe because this patient had a very high intraocular pressure that the cup was also getting deepened. And you usually cannot appreciate the RNFL defects in myopes because of these RP changes, which what they have and the striations are not visible very nicely. So this is what I was going to trying to tell here, that this is a stellar ring which you should not be including in the estimation of the optic disc. And this is the inner margin of the scleral canal. And this is the neuroretinal rim, which is pretty thin. But if you include this as the margin of the optic disc, then you might falsely feel that that my optic disc has pretty healthy NRR when it is not. So even if this patient had pressures not very high, 1920, she had cataract, and the patient did not belong to the patient was poor. So in this case, even in undilated, I mean, if you not dilate the patient, you will not be able to appreciate the exact changes that is actually happening in the fundus just by looking at the optic test. Okay, there is some thinning that is being noticed superiorly, but when you dilate and examine and you see that, you know, the patient already has formed such wedge defects both superiorly and inferiorly. So you, and if the patient, you know that the patient may not be able to afford drops to be put in the eye, then you know, you can discuss the surgical alternative also for this kind of patient. So just by good examination, because you know, okay, if this much of which RNFL loss has happened, then definitely this patient, I mean, already has moderate glaucoma. Like this is another example where if you look minutely, if you look at the the neuroretinal rim, you can see that there is some irregularity which is forming here. So corresponding to which you can also see an RNFL defect which is forming. So what I want to say here is that, you know, it is so important to examine the neuroretinal rim, the rim of the optic nerve, you know, and that is what will give you the clue whether my patient does have glaucoma or does not have glaucoma. So this is a 39-year-old Taylor. You can see the pressures are not very high. If you look at the disc, looks pretty healthy. But actually, when you dilate, you can see this RNFL loss which is present, and that actually confirms your diagnosis. No, this patient is definitely having glaucomatous damage, and whatever pressure. And on the other eye, if you see, it looks pretty normal, but you can see that there can be some amount of bearing which is here, but you're not sure. But when you dilate and see, when you can see this defect, then you know that this patient is definitely having some early changes of glaucoma. So if you ask about the myopic eyes, the myopic's eyes are tilted, they can be torted. And so here comes the importance of the contour cup. So this patient had hand movement and pressure was very high. The other eye was okay. I mean, so you can see that, you know, here the vessels are bending all in the edge. So that is what you're going to use here, because the color is not very good enough to tell you where is my neuroretinal rim, but where the second bend of the vessel is, you'll take that as an indicator for the size of the cup. So you can see here that is almost bending at the edge, and so this person has got advanced glaucomatous damage for which his vision is hand movement. On the other hand, even the left eye optic disc is highly torted, but then you can see that if you look at the bend, you can see that it is still here and the neuroretinal rim is still healthy. In this patient, because of the large peripapillary atrophy, you might get some enlargement of the blind spot. Now coming to the non-glaucomatous optic atrophy, like, you know, you may ask what is the normal color of the disc. The normal color of the disc is usually a salmon pink, and it appears like that because the nerve fiber layer acts as a fiber optic cable which transmits the color from the deep capillaries to the viewer's eye. So a crowded optic disc will look more hyperemic than the myopic disc, which may look pale. So where does the pallor come from? So whenever you have optic atrophy, actually their axons die. So they are replaced by the glial cells on the disc surface, which does not reflect light, and that is why you see this pale color and you do not see. So there can be some capillary dropout also, and the arterioles also, they reduce in size and number. So that is also the other reason that you see this paleness of the optic disc. So the difference between a glaucomatous and a non-glaucomatous optic disc is that, so both of these discs would look pale, but in a glaucomatous advanced damage, the paleness comes because of the absence of the neuroretinal rim. So, but on the other hand, if it is a non-glaucomatous optic atrophy, you can see that there's still some mass that is in the optic disc, and it is not because of the loss of volume, but the volume is there, but it looks pale. So, and but if you look at the RNFL, so both of them might have a diffuse loss. So from the RNFL, you will not be able to make out in advanced cases which is glaucomatous or non-glaucomatous, but the optic disc will definitely tell you the tale. And if you look at the OCT images, a glaucomatous optic nerve will give you a definite biarcuate pattern of loss. So this is typical of glaucoma until there's a very advanced damage. Whereas in a non-glaucomatous optic atrophy, you'll get a diffuse loss of the RNFL. It will not follow any pattern. And in obviously in a glaucomatous visual field, you will get these arcuate defects where the center may still be spared till the end. Whereas in a non-glaucomatous optic atrophy, you'll get this typical altitudinal defect which will respect the horizontal meridian. So the causes of a non-glaucomatous optic neuroatrophy, like, can follow after having an episode of optic neuritis. So what is important in the non-glaucomatous optic atrophy are the history. I think it's very, very important. Like if the patient had this kind of an atrophy because of optic neuritis, now the patient will complain of loss of central vision with a dull retrobulbar pain. And in this kind of patient, is very important that to do a color vision testing, the loss of contrast sensitivity. And RAPD can be a sign in both glaucomatous and non-glaucomatous in the advanced stages. So, but in optic neuritis, RAPD is definitely the sign going on. The second cause for a white pale optic disc can be an arteritis ischemic optic neuropathy. But again, here you will get typical history of a headache, scalp tenderness, jaw claudication, ear pain, and the patient will give you a history of sudden painless vision loss, which never happens in glaucoma. Also, if the cause is an arteritic cause, then the patient may also give you a history of transient monocular visual symptoms. And so in the initial stages, this kind of patient will have a swollen optic disc with maybe some kind of flame-shaped hemorrhages in an RAPD. And the D feature of an arteritis ischemic optic neuropathy is the chalky white edematous disc in the initial stages, and which when with time may undergo some loss of the neuroretinal rim and may appear like a glaucomatous optic disc. But obviously in this kind of patient, you also have to take the intraocular pressure as a consideration. The visual prognosis in these cases is very, very poor. So in this kind of an optic nerve, if it's because of arteritis ischemic optic neuropathy, the vision is very, very poor. But in case of glaucoma, even if you have a little bit of rim that is left nasally, the patient will be able to still read a 6.6 and 6.9, though in a tunnel way, but they will be able to. The third cause is a non-arteritic ischemic optic neuropathy. So these are the discs at risk. Okay, the small, so this usually happens in very small optic disc with no cup. So when so many axons go through a scleral tunnel, they have exoplasmic stasis, and so when the axons swell up, they further lead to more ischemia, and then you get a picture like this. So this kind of patients also have a vasculoparetic risk factors like in hypertension, diabetes, hypercholesterolemia, any vasospasm or impaired autoregulation. Here, the losses typical you may feel that the superior and inferior part, of the neuroretinal rim is appearing pale. And this kind of patients will have a typical altitudinal defect. So you can also get an NAI in a PECG patient. Like this is a 41-year-old male who has bilateral primary angle crucial glaucoma where the pressures are controlled at 3 AGM. So here you can see that normally whatever pictures I have shown you till now, I have shown you that that the neuroretinal rim in a glaucoma patient, unless and until there's something else, they're usually pink in color, unless until the patient is myopic. So, but in this patient, the patient had high intraocular pressure and the neuroretinal rim is also appearing a little pale. So these are the patients when the pressures are very high, some kind of ischemic event had set in, and you get a picture like an NAION. In this also you get the OCT also confirms the diagnosis that there is a diffuse loss of the retinal fiber layer, and it's not in the arcuate pattern. And you can also see that there is biarcuate scotoma in the right eye and inferior arcuate scotoma in the left eye. With an incomplete arcuate scotoma and superior in the left eye. So by looking at the fields, you know that the left eye field is much better, whereas a 10-2 is better in the right eye. It's good in the right eye. So this is another lady who had high pressures in the left eye, had an attack of glaucoma, and then you can also see that the NRR has become pale. So in any patient of glaucoma, if you feel that pressures are very high but still they may have some kind of paleness of the neuroretinal rim because of the ischemic event that had happened when the pressures are very high. So here you can see that the right eye is normal and the left eye has got a diffuse RNFL loss, which is also confirmed by the field test. So in cases of neurological field, you may just get some temporal pallor, and you have to take care of the age also. In a young patient, maybe, the vision is decreasing and there's any other reason to it except this temporal pallor, and corresponding to which you can also see this RNFL loss that's happening in the temporal quadrant. And then when you do a visual field test, you get this visual field which respects a vertical meridian. I think that is the typical sign of a neurological field when they respect the vertical meridian. So any optic nerves where you feel that there's some amount of pallor which is there, just get a visual field test done. It'll tell you if the visual field is respecting the horizontal meridian, the patient will have ischemic optic neuropathy kind of a finding, or if the patient is respecting the vertical meridian, you know that it may be neurological. So this is a typical bow type pattern of pallor that you get in neurological field where there's some chiasmal lesion. So again, you can see that in the field test, it's respecting the vertical meridians. The next differential diagnosis would be a traumatic optic neuropathy. Obviously, in this case, there may be some amount of vision loss depending on what was the severity of trauma, and it's typically unilateral, and definitely the patient will have a history of trauma. So the patient will also have decreased color vision, visual field loss, which may not be very typical. I mean, they can be central scotomas, or they can be centrocecal or altitudinal. So it depends on what kind of damage the optic nerve has suffered that you'll get a corresponding visual field. So here you can see that some amount of pallor has set in, but otherwise the patient is 6'9" and there are hardly any changes. Next comes your nutritional toxic optic neuropathies. Here, I think it is the history is very important. That bilaterally the patient will complain of decreased vision, which is painless, progressive, and obviously if you delve further into it, you will be able to get the nutritional and the toxic, the history of the patient, the medication the patient is on, and when you examine optic nerve, I think the most important is you get a temporal pallor in these patients. So you get a temporal pallor in bilaterally, and as you can see with the OCT also. And I think in a nutritional toxic optic neuropathy, the centrocecal scotoma is the most prominent, the type of field effect that you get. I think the other mimics optic atrophy, like an optic nerve hypoplasia, suppose in this patient, may be referred to you because of this paleness of the optic disc, but actually this is not the optic disc, this is the sclera, and this is the actual optic disc, which is very, very small in size. This is another one, the morning glory syndrome. You may feel that, that this is a large optic disc, maybe glaucomatous, but it is not actually. So morning glory syndrome is very, very, it is typical of itself. Like here, it's not the optic disc. Actually, the optic disc is it's submerged into this excavation, and you can see this blood vessels just like radiating from the optic disc, and you can get some glial proliferation. You'll get this peripigment, pigmentary problems. And the next would be an optic disc pit where the dysplastic retina has actually gone behind through a collagen line pocket and maybe in contact with the subarachnoid space. So this is just a depressed part in the optic disc. And this is not a double optic disc, but it's an optic disc coloboma, where the optic disc, like it is an excavation which is present off-centered but involving the optic disc. This implies incomplete embryonic closure, incomplete or an abnormal embryonic closure. The last is the this metilated nerve fiber. Obviously you not miss it. You not consider it to be glaucomatous, but this is one of the whiteness around the optic disc. The typical feature is a feathery margin, and the vision is normally retained, but except in very severe cases, the vision may be low. So I would like to conclude that evaluation of the optic nerve is very important for the diagnosis, whether it's a glaucomatous or a non-glaucomatous optic atrophy. Very, very good history and a very good clinical examination including the pupillary reaction, the color test, color vision test, the contrast sensitivity. I think it's very important to know what the etiology is. And it is also important to find the etiology in patients with non-glaucomatous optic atrophy, because if one eye, it has happened in one eye, the other eye is always at a risk. I think that is it from my side.